Hi and good afternoon, everyone. I'm Dr. Menaga from Hospital Wanita dan Kanak-Kanak Sabah. Today, I'm going to be talking about handling obstetric emergencies in the operating room. So before I go on to my presentation, let me just give an overview on what I'm going to talk about. We'll start off with the definition of obstetric emergencies, how to handle a crisis, and then I'll move on to the common anesthetic emergencies that we encounter in our hospital. So obstetric emergencies are actually life-threatening health problems that affects the pregnant patient and the baby. It can arise anytime in pregnancy, during labor, or even postpartum. And it often always involves a multidisciplinary involvement, such as the obstetric team, the emergency department, especially if the patient is coming from home or a different medical center, medical team, and the anesthesia team. So when it comes to handling a crisis, using these 4 steps to actually address the emergency helps in handling the crisis. So when you get posted, when the case is posted, you need to identify a quick run through of the current emergency in terms of the diagnosis, symptoms, and the urgency of intervention. Also relevant would be the past medical, surgical, and anesthetic history that can affect the anesthesia that is going to be given to the patient. In terms of communication, we need to communicate with the obstetric team, the emergency department, medical team, blood bank, and other relevant teams, because we need to come up with a working diagnosis, urgency to deliver, and whether any optimization is needed for the patient. We also need to give time for the blood bank to prepare their bloods, especially when we request for the massive transfusion protocol. So once you have identified the issue or the crisis, inform your senior MOs and anesthetists in charge to help and plan. It's also important to inform other team members such as the OT and ICU staff so that they can help to prepare the OT and also mobilize a bed for the patient post-operatively. So moving on, once we have done all that, preparing the OT is important. We need to see what is the mode of anesthesia that is going to be given to the patient. Usually that is decided by the anesthetist in charge. Preparing in terms of anticipating what are the adverse events that can happen, such as a failed regional or a difficult intubation. And also setting up your OT means checking the equipment, preparing your drugs according to the patient, and also getting your fluids and warmers ready. So the common emergencies that occur in our hospital setting are the major obstetric hemorrhage and eclampsia. That is actually pretty common in our setting. Amniotic fluid embolism and maternal collapse, although it's rare, but we have encountered it. So when it comes to definition of major obstetric hemorrhage, there's various definitions provided by different guidelines and different protocols from the obstetric team. So what we can do is divide it into antepartum hemorrhage, early pregnancy hemorrhage, and postpartum hemorrhage. So here are the common causes of antepartum hemorrhage, whereby we can further subdivide into placental and local. Early pregnancy hemorrhage usually is the molar pregnancies, ectopic pregnancies, or complications from miscarriages, such as your retained placenta, retained tissue, or sometimes during diagnostic and curettage. They can actually injure or perforate the uterus, and that can cause bleeding. Next, we go on to a postpartum hemorrhage, whereby it's loosely defined as a blood loss of more than 500 mils if the patient delivers vaginally, and more than 1,000 mils if the patient undergoes C-section. And most of the time, there is The causes can be subdivided under the mnemonics of 4 T's, which is atony, trauma to the birth canal, retention of fetal or placental tissue, or coagulopathy and thrombin disorders. So the challenges in major obstetric hemorrhage because it can be rapid, it can be life-threatening, inability to quantify the exact blood loss because the blood actually can be concealed in the vaginal tract. It can be in the drapes and the gauzes. It will be difficult to actually point out the exact blood loss. And the high uteroplacental blood flow, which is about 700 mils per minute, can cause the patient to go into a hemorrhagic shock very rapidly. And of course, the inability to identify the risk factors, especially in unbooked cases, or if the patient comes in urgently for a delivery without having time for us to actually clerk or go through the history and identify the risk factors. So when we want to identify a major obstetric shock, a major obstetric hemorrhage and the degree of shock, we can either go clinically or through the shock index. Clinically, we use the rule of 30, which is a reduction of 30% of blood volume. Your systolic BP, hemoglobin, or hematocrit can also drop by 30%, or your urine output can reduce up to less than 30 mils an hour. And your heart rate can go up by 30% and respiratory rate more than 30 per minute. Shock index, although is rarely used, but it can be useful when you actually divide your heart rate over your systolic blood pressure. So your normal range is 0.5 to 7, and it can go up to 0.9 in pregnant patients. So anything higher than that shows that the patient is going into a hemorrhagic shock. So once you have identified major obstetric hemorrhage, it's important to call for help early, inform your senior MO and anesthetist in charge, communicate with the obstetrician to rectify the causes and amount of bleeding. You need to call the blood bank to cross-match blood, and it's important to also communicate with the patient because sometimes they are under regional anesthesia. So you need to assess for signs of shock, such as dizziness or nausea or lethargy. Resuscitate, you need to start by giving supplementary oxygen to the patient, regardless of the saturation, because you actually want to optimize their blood oxygen levels. Ensure good functioning IV access, but it can be difficult to get a good line, especially if the patient is bleeding away and the BP is low. So make sure you have resuscitated properly before you actually want to attempt to insert another IV line. Ensure that the patient is kept normothermic, because once the patient starts bleeding, you want to actually get your clotting factors activated to speed up the process of clotting. So in order for that, the liver has to be in a normal temperature. So make sure that the patient is kept normothermic. Permissive hypotension, defined as a systolic BP of 80 to 90, actually helps in reduction of blood loss, but make sure that it's only for 1 hour and does not exceed 1 hour. And you also have to start monitoring your urine output. So to convert or not, okay, this is a very important question. You need to communicate with the surgeon to see whether the bleeding has stopped or whether they want to proceed with a hysterectomy. If the time into surgery has exceeded 2 hours or the patient's general status and hemodynamics has deteriorated, then probably it's best to plan to convert with the help of the senior MOs and the anesthetist. But please remember that early intubation does not stop the PPH. It enables rapid resuscitation in a decompensating patient. Pharmacological resuscitation is also important. Your uterotonics should be given early, especially in uterine atony, communicate with the surgeon on the best suitable uterotonics. Give your fluids, can be crystalloids or colloids. Tranexamic acid has been proven to reduce mortality from postpartum hemorrhage by 30%. Your blood products is important, and sometimes calcium gluconate is necessary as it can also help in activating your clotting factors in the liver. So what are the goals of resuscitation? You would want to aim for a HP of more than 8 grams per deciliter, a platelet of 75,000. Prothrombin time and your APTT should be lesser than 1.5 from the mean control. Aim for a fibrinogen of more than 2 grams per liter and a pH of more than 7.2. And post-operative monitoring, you should send the patient to HGW or ICU care because you want to repeat all your blood investigations and optimize them further. You also need to watch out for transfusion-related acute lung injury, especially if there was overzealous blood transfusion, and continue to keep the patient normothermic. So next we'll go on to eclampsia. It's actually convulsions or coma occurring during pregnancy that is not caused by a neurological disease, and it has conditions that meet the criteria for preeclampsia. So features of preeclampsia, what is important is the box that is in green. They usually come with, sometimes they come with severe clinical signs such as a new onset of pulmonary edema, cerebral or visual disturbances. And the seriousness of preeclampsia would be from a HELP syndrome, whereby there is hemolysis, elevated liver enzymes, and low platelet. That shows that the patient is deteriorating fast. So again, identifying the issue. Criteria is based from what I said above and also from the history. Eclampsia is always a red alert, so be prepared to attend to the patient. Patient can be in the ward or in the emergency department, or sometimes even during surgery, the patient can actually fit. Also look for other clinical presentations such as acute pulmonary edema, pitting edema, or low urine output, and see the complications of eclampsia such as intracranial bleed or congestive heart failure. Call for help early, inform the anesthetist in charge, and communicate with the obstetricians, because almost always eclampsia means planning the delivery early. You need to get the baby out so that the blood pressure actually comes down. So resuscitation, we start off by airway, breathing, and circulation. Ensure that the patient has supplementary oxygen. Assess the GCS and pupillary changes. Put the patient left lateral with a jaw thrust. This is to actually reduce or minimize aspiration. Ensure that the patient has IV access for drugs and fluids. Put on your monitorings and consider intubation if the convulsions is not aborted. So your first line of anticonvulsants is your Maxalf, which is a cerebral vasodilator. You can also give your antihypertensives such as beta blockers and vasodilators to bring down the blood pressure. And preparing your OT involves cross-matching of bloods because the patient can actually have postpartum hemorrhage. Preparing your OT and preparing an ICU bed for post-op monitoring. So in terms of intraoperative management, what we want is a BP control. So we actually want to target our BP lesser than 160 over 110 millimeters mercury. It's best to continue the Maxalf maintenance dose until after the surgery. But sometimes with your volatile agents, your BP actually comes down. So you have to be a bit cautious on the rate of magnesium sulfate that you want to give intraoperatively. And magnesium sulfate can cause uterine atony, so watch out for your PPH. Be very careful with your fluid administration because the patient can develop acute pulmonary edema. Monitor your urine output And be cautioned with certain uterotonics such as symptometrin or hemabate because that can further increase your blood pressure. Post-operative care involves ICU or HDW monitoring. If the patient is ventilated, then you may need to cerebral protect the patient for 24 to 48 hours. A CT brain is warranted, especially if you want to look out for an intracranial bleed and an echo to see for signs of heart failure. And watch out for magnesium toxicity. So you have to check your magnesium levels, you have to check your urine output, and also check the patient's reflexes. And please do a strict IO charting. Next, I'm going to talk about amniotic fluid embolism. It is actually a very catastrophic event that happens when the foreign body, either amniotic fluid or fetal debris, enters the maternal circulation, causing a sudden and profound maternal collapse. It's usually a diagnosis of exclusion, and it comes with a triad of hypoxia, hypotension, and consumptive coagulopathy. Each can occur at a different time, but when you see retrospectively, these are the three things that occurs in a patient that you suspect of amniotic fluid embolism. So identifying involves the clinical presentation. The signs, the patient can suddenly complain of dyspnea, cough, headache, chest pain, or the patient can become disorientated suddenly. Symptoms, although hypotension is part of the triad, sometimes they can present with hypertension before the embolism sets in. They can also have bradycardia, seizures, pulmonary edema, and sudden cardiac arrest. So communication, you need to call for help urgently because it's actually an obstetric and anesthetic emergency. Update the surgeon, make sure that baby is delivered immediately to improve the cardiac output. And you need to start cross-matching your blood because the DIVC sets in almost immediately. And in terms of resuscitation, again, airway, breathing, circulation, put on your monitoring, put on your oxygen, prepare to intubate the patient if the patient is under regional anesthesia. You might need to start cardiopulmonary resuscitation if there is maternal collapse. For seizures, you can actually give your benzodiazepines such as midazolam or barbiturates and prepare for PPH as DIVC may set in. And post-operative care is ICU, cerebral protect the patient, do a CT brain to see the degree of cerebral edema, especially if there was a hypoxic event, do an echo also to look for any heart failure, and also correct the coagulopathy and electrolytes. Next, we go on to maternal collapse. So maternal collapse, and there's actually a very nice mnemonics to point out causes of maternal collapse known as the BUCHOPS. It can be further subdivided into obstetric causes and anesthetic causes, which I'm going to talk about later. So it starts off with identifying the causes of collapse, whether it's reversible or not, and location of collapse. Maternal collapse can occur anywhere. It can occur in the emergency department, it can occur in the ward, it can occur in OT during a surgery. So just be prepared for it. Communication, inform your superiors and anesthetists. Again, this is a catastrophic event. You also need to communicate with the obstetric team and the attending team. Resuscitation involves ABC protocol. Commence your CPR with a wedge or pillow below the right buttock. It actually is to obtund your aortocaval compression that would increase the cardiac output of the mother. Securing of airway should be done by the most experienced MO or the anesthetist because you don't want too many attempts of intubation. You want the tube to go in as soon as possible with a single attempt. Perimortem Caesar should be thought about if the pregnancy is beyond 24 weeks of gestation. So within 4 minutes into the CPR, the obstetrician needs to start the perimortem Caesar to deliver the baby by the 6th minute. Oops. Let me go back, sorry. Yeah. So after the return of spontaneous circulation, the patient has to go to ICU for post-cardiac arrest care. And that's also where we want to treat the underlying cause for the maternal collapse. Okay, so as I said earlier, maternal collapse can be divided into obstetric causes and anesthetic causes. And now I'm going to talk about the anesthetic causes of maternal collapse. Okay, so failed intubation. What you need to remember is all pregnant patients, regardless of their weight, regardless of their BMI, is a difficult intubation unless proven otherwise. So in terms of why they are difficult intubation, we can divide into anatomical features and physiological features that makes it a difficult intubation. So in terms of anatomical features, so all your progesterones actually can cause capillary engorgement, and that further causes mucosal edema of the airway. So sometimes when you do a laryngoscopy, you see that the airway is very edematous and you might need to use a smaller ETT. Your enlarged breast can actually obtund your laryngoscopy. So a shorter, you might need a shorter hand, you will need a shorter handle when you intubate a pregnant patient. Maternal obesity, you will have features of short neck or the face is big. It'd be difficult to hold your mask. So these can cause a difficult airway, and the gravid uterus causes a raised intragastric pressure. So patient is more prone for aspiration. And physiological features, the most important is the reduction of your functional residual capacity by 20% and your expiratory reserve volume by 25%. So patients will desaturate very fast, regardless of how long your pre-oxygenation you do. They can desaturate actually very, very fast. So when it comes to giving general anesthesia to a pregnant patient, get help. You definitely cannot do it by yourself. Plan the intubation steps with teamwork and always anticipate adverse events such as a failed intubation or a failed ventilation. So get all your airway adjuncts and your difficult intubation trolley set up. So preparation, check your GA machine and your intubating trolley. Make sure all your adjuncts are there. Make sure everything is functioning. Prepare a ramping pillow. You might need it. Get the aspiration prophylaxis into the patient. Here we usually give sodium citrate and ranitidine. Maxolon is optional. Adequate pre-oxygenation. Sometimes in a crisis, it will be difficult to wait for that 5 minutes of pre-oxygenation. So what you can do is hold the mask tightly on the patient's face and ask them to take 4 vital capacity breaths. Rapid sequence induction and cricoid pressure is a must, regardless of the fasting time. And titrate your drugs according to comorbids and your weight, meaning that your muscle relaxants should be given according to your weight. Don't reduce your muscle relaxants, because that will further obtund the intubation. So the Difficult Airway Society came up with the algorithm for intubating a pregnant patient and what to do when there is a failed tracheal intubation. So just follow all the steps, and you can actually get it online. You can go to the webpage, the Difficult Airway Society webpage, and you can go through this algorithm. So each of you all need to go through this algorithm before you handle an obstetric patient. And a failed intubation causing maternal hypoxia is almost always due to a failure to oxygenate rather than a failure to intubate. Just remember this. So always try to oxygenate rather than to just get the tube in. Make sure that your oxygenation is optimum. Next, we move on to high spinal. This is actually a sensory motor block from a neuraxial anesthesia that reaches a spinal segment that is higher than the intended surgical site, causing a cardiovascular compromise. So the risk factors in an obstetric patient is short stature of less than 150 centimeters, so obesity, because in an obese patient, the venous engorgement can further increase the risk of a high spinal. So identifying, actually the symptoms and signs occurs according to the root levels. And what I need to point out is your level of C3, C5 and your intracranial spread, because when it hits these levels, usually you need to convert to general anesthesia as soon as possible. So make sure you have identified which level the high spinal has gone to. Management, recognize that it's a high spinal, call for help. Lateral tilt of the uterus to obtund your aortocaval compression and to also increase your cardiac output. You need to treat the hypotension with fluids, give up to 1 liter and boluses of your phenylephrine. So your phenylephrine and also the high spinal can cause profound bradycardia, which needs to be treated with atropine. Secure the airway in respiratory compromise. Certain conditions, your patients can actually arrest, so you need to start your CPR. And ventilation is usually until the neuroaxial block wears off, so it can take probably more than 24 hours. Okay, next we go on to LA toxicity. So LA toxicity is an inadvertent injection of local anesthetics into the systemic circulation. The common mistakes that can happen is when you give your epidural infusion through the IV line, or sometimes you give your epidural boluses through an IV line. So this can cause your inadvertent LA toxicity. So your symptoms, it can actually affect the neurology or your cardiac system. So in terms of neurology, you can have a sudden altered mental status, loss of consciousness, or the patient can start fitting. And in terms of cardiovascular system, patient can actually have a cardiac arrest, or you can see some conduction blockades. So management is call for help early, stop injecting the LA, secure your airway, and once secured, try to hyperventilate the patient because it actually increases the plasma pH in the event of metabolic acidosis. You might need to start CPR for the patient. Give your anticonvulsants such as midazolam or barbiturates, and treat your arrhythmias, bradycardias, and hypotension. Okay, so the most important drug in LA toxicity would be the intralipid drug. All MOs need to know the location of the intralipid drug in your OT. It is actually an intralipid 20%. It looks like this white color in a bottle. So once you encounter LA toxicity, you need to prepare, give 1.5 mils per kg over 20 minutes, repeat at 5-minute intervals. You can give up to 3 times your bolus before starting your infusion. Infusion, you can run from 0.25 mils to 0.5 mils per kg per minute. Once you have given your intralipid drug, you need to send the patient post-op for ICU monitoring. Repeat your liver enzymes and lipid profile because a patient can get transaminitis or dyslipidemia from the amount of intralipid that is given. Okay, next we move on to drug errors. Okay, so drug errors is actually inadvertent injection of, inadvertent injection of wrong drugs, wrong dosage, or wrong route of administration. You need to identify type of drug given, the toxic dose of the drug, whether there's any antidote available, whether the drug is dialysable or not, and effects that can occur in the patient or the fetus. Inform your superiors and the anesthetist. Inform the obstetric team. You may consult the pharmacist for a better drug info profiling. So management involves, again, your airway, breathing, and circulation. Stop administering the drug. Give your IV fluids because you want to try to flush the drug out through the urine. Watch out for adverse effects based on the drug profile. Sometimes it's necessary to secure the airway. And sometimes if the drug is very toxic and dialysable, the patient might need hemodialysis. So how do we prevent drug errors? You need to read up on all the drugs that you use in the OT and the side effects. Read the ampule of the drug before you open the ampule. Label your syringes, including the time and date of preparation, and do not reuse your syringe and needle for different patients. Before you administer the drug, you please check your syringe in your labeling and administer your drug slowly in aliquots via a functional IV access and a running drip. Next, we go on to anaphylaxis. So it's actually a hypersensitivity reaction mediated by the immunoglobulin E to an antigen causing serotonin and histamine release. So here I'm going to talk about mainly about anaphylactic shock, which occurs as a CVS collapse. So the National Audit Project done in the UK came up with a NAP6, which is perioperative anaphylaxis. And they identified that the most common trigger for anaphylaxis was antibiotics, 47%, followed by muscle relaxants. And the muscle relaxants that caused the most anaphylaxis was rocuronium, probably because rocuronium is widely used compared to other muscle relaxants. So from the NAP6, they have actually come up with a few new guidelines on how to resuscitate a patient that goes into an anaphylactic shock. You need to call for help, stop administering the trigger drugs, and you need to stop your colloids because sometimes colloids can also cause anaphylaxis. Airway, breathing, circulation, again, give 100% oxygen, start giving crystalloids, and commence CPR if the systolic BP is less than 50 millimeter mercury. So in anaphylaxis or anaphylactic shock, your drugs of choice is IV adrenaline, 50 mics. Give boluses until the pulse pressure improves, meaning you want to aim a systolic BP of 80 and above. Or IM adrenaline, 0.5 to 1 milligram every 10 minutes. Give your Periton 10 to 20 milligrams IV and your Hydrocot 100 to 300 milligrams. Sometimes in bronchospasm, you have to give your bronchodilators. And if the patient goes into anaphylactic shock, you might need to start your vasopressors. So start with your adrenaline infusion. And intraoperatively, when the anaphylaxis occurs, inform the obstetrician, aim to deliver the baby as soon as possible because you want to increase the cardiac output of the mother. And if there is CPR, tell the obstetrician to do an immediate resuscitative hysterotomy. So post-operatively, it's important to send the patient to ICU. We need to cerebral protect the patient, especially in events of cardiovascular collapse. Restore your hemodynamics and relieve the bronchospasm. You may need to take your serum tryptase just to see the extent of the mast cell activation. Okay, so that comes to the end of my presentation. So handling an obstetric crisis involves practicing safe anesthesia. You don't want to be superhero. It's not important to be a superhero, but I think it's more important to just practice safe anesthesia, get help as necessary. You need to identify quickly, communicate effectively, inform your superiors, inform your colleagues for help necessarily, and prepare your OT diligently. So with that, I thank you. These are my references, and you can actually email me if you have any questions regarding obstetric anesthesia. I'll be more than glad to help. Thank you.